Good afternoon. My name is Tess Taylor, and I'm a specialist with the Community Education Department at MDA. We're thrilled to have you join us for today's webinar, Advances in Gene Therapy, Understanding Options and Decision Making. This learning event is part of our larger MDA Community Education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their inbox. Please know that all phone lines have been muted, but you can still ask questions. You can use the Q&A feature or the chat feature to ask your questions, and we'll have a Q&A session at the end of Dr. Matesanz's presentation. I also want to mention, if you had a question at registration, please go ahead and put that back in the chat so we can ensure that we get to it as we prioritize our live attendees for those questions. MDA would like to thank our program sponsors, Regeneron Pharmaceuticals, Regenx Bio, and Sanofi for partnering with us on today's webinar. For 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center network, and advocating for access and inclusion for the neuromuscular disease community. The purpose of our program today is to explore the latest advances in gene therapy for neuromuscular diseases, including how these therapies work, how they're delivered, and what new treatments could mean for individuals and families. Our presentation will be followed by a brief Q&A session with our speaker. And now it's my pleasure to introduce our speaker, Dr. Susan Matesanz. She is the attending physician and the medical, she is an attending physician and the medical director of clinical in vivo gene therapy at the Children's Hospital of Philadelphia. So hi, Dr. Matesanz. Thank you so much for joining us today. And I will turn the time over to you.
Great. Thank you to the MDA for having me today. Give me 1 second to pull up my slides. And so I'm, looking forward to talking about this with you all today. There is so much happening in the field of gene therapy that we're just going to scratch the surface a little bit today. I wish I had the time to get in depth into the science of all the different exciting trials and research that's happening, but hopefully we'll at least have the chance to go over a broad overview of how we think about gene therapy and some of the things that are coming down the pipeline. So as Tess mentioned, this is the agenda for today. And so we can't talk about gene therapy without flashing back to high school or college biology class. And so in our cells, we have the nucleus, kind of the brain, I guess, if you will, of our each individual cell. And in the nucleus lies our DNA, which is double-stranded. And in the DNA, we have genes, and every gene encodes for a different protein. And so DNA, double-stranded DNA is transcribed into single-stranded RNA. Then it's spliced or sort of cut up, exported from the nucleus. And then what's called messenger RNA is translated into a protein. And every protein in our body has a different job. And so when we have genetic diseases, there are typically, changes in that genetic code that lead to how much of a protein is made, either too little or too much, perhaps the function of the protein, whether it might be folded abnormally, and those things can cause different types of diseases in humans. And so when we're talking about gene and cell therapy, it's quite a broad-based term. And so we can think about whether or not a given therapy is DNA directed or RNA directed. And we can think about, is it a gene transfer therapy? So is it giving you a new copy of a gene? Is it a gene editing therapy? So is it editing your own genetic code? Or is it RNA based? Is it preventing a protein from accumulating? Or is it preventing a protein from being spliced or cut up abnormally? Is it blocking a protein from coming out of the cell. So there are different sort of ways to approach. Currently, our approved gene therapies are primarily those that are given via adeno-associated virus, and we're going to talk in a lot more detail about what that is, as well as some of our RNA therapies like antisense oligonucleotides. And so, again, this is just some of the common terminology. The American Society of Cell and Gene Therapy has a sort of glossary website. So these definitions are pulled from there. And so when we use the umbrella term gene therapy, it's really just talking about the use of genetic material to treat or prevent disease. And so when we talk about gene addition, that means we're adding in instructions to make more of a specific protein. We give those instructions via a vector, which in this case is often a virus. And so the example here is AAV gene transfer. Gene silencing is kind of doing the opposite. We're actually trying to turn off a gene in a body to prevent the body from making a specific type of protein or decrease the amount of protein being made. When we talk about gene editing, we're actually changing your own genetic code, so the code that sort of lives in your nucleus, to correct the protein sort of at the very first step of the process. And so if you've heard of CRISPR or Cas9, this is often used to make gene editing changes. And then RNA therapy is the use of shorter sequences, so the single-stranded RNA, to treat or prevent a disease. And there are many, many different types of RNA therapy because there are so many types of RNA sequences that can affect cell functions. And these therapies often need repeat dosing to maintain a therapeutic effect, since the DNA itself is not being altered or supplemented. And for purposes of today's talk, we're going to be primarily talking about gene transfer therapy. And so then to just, further break it down, we talk about in vivo gene therapy and ex vivo gene therapy. And so when we talk about in vivo gene therapy, we take a vector and we give it directly back to the patient, often via an IV infusion or via something like a lumbar puncture. Whereas with ex vivo therapy, we take the patient's cells out of the body. We then put the vector into those cells, and we give that therapy back, typically via a bone marrow transplant. And ex vivo gene therapy has been used in things like sickle cell disease or certain types of leukodystrophies. That's been not typically used as much in neuromuscular disorders. And so, we talk a lot about AAV therapies. And so I think it's important to step back and ask ourselves, what actually is AAV? And so AAV are small, non-enveloped viruses that belong to a family of viruses called the parvovirus family. They're naturally occurring, so they're out there in our environment. They're quite common. They infect multiple species, including humans and non-human primates. And in spite of being quite common, they don't actually cause disease in humans. And this is thought to be because the AAV can't make copies of itself outside of the body. And they're dependent on co-infection with other viruses, and specifically with adenovirus, for their replication. It's quite a simple virus. It has a single strand of DNA, and it's about 4.7 kilobase pairs long. So that's kind of the packing capacity. You can think of that as sort of the size of the box, and we'll talk a little bit more about that. And then if we use the term rAAV, that just means that it's recombinant, meaning sort of something that was adjusted or made as opposed to a type that's naturally circulating in the environment. And so far, there have been 8 FDA-approved AAV gene therapies. So starting in 2017 with Luxturna, which is given into the eye for retinal dystrophy, and then all the way up to less than a month ago when Visma was approved for older patients with SMA. And in the neuromuscular world, we actually have 3 out of the 8 approved therapies. And so, thousands of patients have now been treated worldwide. And the experiences with these gene therapies are informing clinical development across many other neuromuscular diseases. And so, when we think about the structure of AAV, I like to give my patients this analogy that you can think of your AAV kind of like an Amazon package. And so your vector is your box, your promoter is your address label. So the promoter's job is to tell that box where in the body should we deliver to. So do you go to the muscles? Do you go to the heart? Do you go to the liver? And then the transgene, which is the actual instruction manual to make the target protein, is the actual contents of the box. And so these three components work together to help the body make a different version of a particular protein. And again, I go back to this point about packing capacity. So the survival motor neuron protein is a small protein, so the entire protein fits into the box, whereas the dystrophin protein is quite a large protein, and so the entire thing of full-length dystrophin does not fit into your box. So again, if you have an Amazon package for a book, you can't really shove a couch into it. And so, gene therapy has led to remarkable advances, but it's not without its challenges. And we're going to kind of go through each of these things: toxicity, efficacy, access and cost, and capacity, and talk about some of the lessons we've learned and how that's shaping our future therapies. And so in neuromuscular diseases specifically, the muscle and the nerves are large organs. And many neuromuscular disorders, as we know, have multisystemic manifestations. They affect the muscle, they affect the heart. And so this means that the doses needed to get into the target tissues that we want to influence are often very high, which can increase the risk of toxicities. And so if you go back a couple slides, I highlighted that some of the other gene therapies that are approved have been studied in hemophilia. And the doses of AAV used in neuromuscular diseases are around 1,000 times higher than the doses used in hemophilia, which is a blood disorder. And a dose of 1e14 represents 100 trillion viral particles. So that's a lot of virus that we're getting into the body. So this is a challenge for both toxicity and efficacy. And you need this large dose to have the positive effect. And so, with the thousands of patients who've received AAV, both commercially and through clinical trials, we've learned more about sort of toxicities. And over the last, 5 to 8 years, we are gaining more of an understanding of what toxicities we look out for. And so while some toxicities are vector specific or disease specific, I think we've also learned that information sharing across programs, across different disease types are incredibly important because overall these severe side effects are rare. And so we want to learn from each other across different fields of medicine. And so we tend to think about toxicities in kind of the early window, driven by sort of your innate immune response. And we're going to talk more about that a little bit later, versus delayed toxicities driven by kind of your adaptive immune response. And toxicities are more common at higher vector doses, or if you have a second immune hit in close proximity to dosing. So we've learned over the years that it's really important for patients to stay nice and healthy leading up to gene therapy. And so this is just kind of a different way of breaking down some of the toxicities that have been seen across different programs and across different doses. And I know this slide is a little bit busy, a little bit hard to read, but you can see that many of these toxicities are seen at doses of 10 to the 13th or 10 to the 14th, so sort of high dose toxicities. So another challenge in the neuromuscular space is efficacy and durability. So most of our current gene therapies, because we're specifically talking about gene transfer, can slow or halt progression, but they cannot typically alter damage that has previously occurred. And so the current applications of gene transfer for neuromuscular diseases are non-integrating. And so again, that means that the gene transfer isn't directly altering your own DNA. It kind of sits next to your DNA and provides that instruction code for the protein. And so that means that if the cells divide, the gene therapy transcript might only be included in half of those, and the effect may get diluted over time. And so in theory, things like muscle cells have very slow turnover, but in a diseased muscle, a cascade of inflammation and impaired muscle regeneration can affect this process. Another challenge in terms of toxicity and access is antibody positivity. And so, as I mentioned earlier, AAV is non replicating and it's found at a large rate in the community. And the antibody prevalence can vary greatly by age and by geographic region. And while there's no guarantee that if you have antibodies to one type of AAV, you will have antibodies to all types of AAV, there is a fairly high cross reactivity between the different serotypes. And if you have antibodies at this point, that means you cannot get gene therapy or AAV based gene therapy. And so you're excluded from the current treatment. And you can see, again, these are more of the wild type AAVs, but prevalence of some of these wild type AAVs can be as high as 40 to 50%. So that means there's a large segment of the population that's excluded from even considering these therapies. And so, additionally, when you give an AAV gene therapy, the body then starts making antibodies at a very high level. And so that means that right now these are one-time therapies. You can't give future doses. And so, in one study of 101 boys with AAV, with Duchenne muscular dystrophy, the seroprevalence rate was around 30%. In another study, the seroprevalence rate was about 14%. And so, ranges based on, like I said, geographic region, age, race, and ethnicity. And there are ongoing strategies looking at how do we overcome antibody positivity. But it can be a stressful part of, families and patients who are waiting for treatment as they wait to sort of find out their antibody status to see, is this even an option on the table for me? Another access challenge is the cost of these therapies. And so these therapies are highly complex to manufacture and have price tags in the millions of dollars. And so fighting with insurance companies can be a barrier to treatment and also a really stressful part of the process for patients and families. And I know this webinar is focused to a US-based group, but many of these therapies are only available in select countries and so aren't yet accessible to patients across the globe. And because these therapies are expensive to develop and expensive to manufacture, for very rare diseases, there's some concern that there's less incentive for companies to develop these complex therapies. And so, there are lots of conversations about, can there be things like shared manufacturing platforms, collaboration between government and industry to lower the research and development costs and to incentivize the development of therapies for rare disease. And advocacy organizations like the MDA are critical in sort of driving these types of conversations forward. And so long term, there need to be strategies to reduce costs and to increase access, both for patients across the globe and for diseases that may be less common and rare, so that patients with a wide variety of neuromuscular diseases, not just the most common neuromuscular diseases, can access precision genetic medicine treatments. Another unique challenge is the system's capacity. And so one of the big lessons that we've learned is that the administration of these types of therapies is very labor intensive. It's labor intensive for families and patients, and it's also labor intensive for hospitals and treating physicians to make sure that all of the necessary infrastructure to safely care for patients is up and running and in place. And so these therapies often require frequent visits, frequent labs. In some cases, patients might need hospitalization to treat or manage side effects. And often novel clinical trials might require admissions in hospitals. And as we touched on in some of the toxicity introductions, the complications can be multisystemic. And so you need kind of a broad-based team who's able to help manage patients in the case of complications, and patients might need urgent visits. Additionally, you need adequate space in the hospital, which is something we don't always think of as physicians, right? But it's not just the time for the visits, it's making sure that we have all the necessary equipment and capacity, things like pharmacy hoods or infusion space. And so healthcare systems must plan in advance for the growth of these therapies to ensure that those resources are in place. Because once an approval comes down the pike, patients understandably want to get these medications as quickly as possible. You guys have all been waiting for a really long time for treatments. And so we need to pre-plan as much as possible. And so not all healthcare systems have the resources to give these complex therapies. And so we need to build systems that allow patients to access these therapies regardless of where they live. In addition, patients also might need to have a clear understanding of what's required of them during the treatment period. So how often are we asking you to come for labs? How often do you have to come for visits? How long do you have to stay near your treating center? And so I'm going to pivot a little bit to talk about some of the lessons we've learned in terms of efficacy and effectiveness from some of our current approved products. And so we'll go through each of these, but early treatments can influence outcomes of these therapies. Clinical trial endpoints can be challenging in heterogeneous rare diseases. Labels may be broader than what was studied in clinical trials, and physicians and families are left to try to extrapolate risks and benefits for patients. And real-world data is important in understanding long-term benefits of these therapies. So just to talk briefly about spinal muscular atrophy, because that's kind of the gene therapy that started it all in the neuromuscular disease space. So spinal muscular atrophy is a disease that affects the motor neurons caused by homozygous deletions in their survival motor neuron protein. It has an approximate incidence of 1 in 11,000. Without treatment, it leads to progressive proximal muscle weakness, and classically, this protein is so important that we all have backup copies of the gene. And those backup copies, instead of producing 100% functional protein, get spliced or cut up abnormally and only produce about 10% stable protein. And so typically, the more copies of SMN2 you have, the less severe your disease phenotype is, but variation does exist. And so before we had these incredible treatments, the untreated natural history study for the most severe type, which is about 50 to 60% of patients, was death or full-time respiratory support by the age of 2 years. And prior to the treatment options that we now have, it was the most common fatal inherited disorder of infancy. And so I won't go into this too much, but just to say that prior to treatments, we classified SMA type by the highest motor milestone achieved. And so these are kind of the different subtypes of SMA. And so as mentioned, we now have multiple fabulous treatments for SMA that are drastically altering the disease phenotype. 2 of these are AAV gene therapies, and 2 of these are RNA-based therapies. And so Zolgensma, which is the IV AAV therapy, in the initial pivotal trial, it was 15 patients with SMA type 1. All of them were symptomatic at the time of enrollment. And at the end of the study, all patients were alive without permanent ventilation, which was a remarkable milestone. And in the long-term follow-up studies, 11 out of 12 patients were now able to sit. And this is a group of patients that would have never been expected to reach this milestone. And even more remarkable is 4 of those 12 had learned to walk. And so that led to the realization that it's like, okay, let's treat even earlier. And so the next trials were focused on babies who were pre-symptomatic. And these were babies with 2 and 3 copies of SMA. And you can see that the vast majority of these babies achieved milestones like walking. And so, this was an important lesson that the earlier you treat, right, before the disease has progressed, the better patients do. And so shifting a little bit to Duchenne muscular dystrophy, which is the other disease for which we have an approved AAV gene-based therapy. Duchenne is the most common childhood onset muscular dystrophy. It's X-linked inheritance. leads to progressive weakness, cardiomyopathy, and respiratory failure. And Duchenne is sort of the severe end of the dystrophinopathy spectrum, which is a spectrum of disease. And classically, patients with Duchenne have what's called out-of-frame mutations, meaning the puzzle pieces don't fit together and they don't make any functional protein, whereas patients with Becker muscular dystrophy tend to have in-frame mutations, so they make some protein, but it's not as functional as it should be. And dystrophin you can think of as kind of the shock absorber in your muscle cells. And when that shock absorber or trampoline doesn't work, there's a cascade of membrane instability, calcium infiltration, inflammation, oxygen deprivation, fibrosis, and muscle cell death. And so up until recently, steroids have been the mainstay of treatment. As mentioned on a previous slide, dystrophin is a very large protein, and so it doesn't fit into the typical AAV packing capacity. And so this is a busy slide, but I think the lessons from DMD are important as we, study other neuromuscular diseases, as many of these diseases are slowly progressive and patients' experience is unique. And that means that every patient's trajectory is a little bit different. And because of this, it can be hard to pick the best endpoints for a clinical trial, right? Like, how do we actually evaluate if a medicine is working or not? And so, these figures are quite busy, but this is work out of Francesca Montoni's group in England. And these are individual North Star ambulatory assessment trajectories for boys with Duchenne. And you can see that, the curves are quite unique and that everyone has, while similarities, everyone has a little bit of a unique phenotype. And so how do you best sort of evaluate effectiveness of these drugs and these rare diseases? And it might take years to understand the true impact of our therapies. And so our current gene therapies for Duchenne are all versions of microdystrophin. Again, we can't fit that full protein into the AAV packing capacity. So companies have looked at giving mini versions or micro versions of the protein that are still functional. And so you can see full-length dystrophin at the top. And I like this visual because I think it emphasizes that like I said, our current therapies are not the full version of the protein. So at the top, we have Elevidys, which is our approved therapy. The second therapy was the Pfizer clinical trial product that unfortunately failed in clinical trial. And then the bottom three are ones being studied right now. Solid and Regenexx are both here in the United States. And we're not going to get into today just all of the nuances of the data on Elevidys, just because we don't have time. But one lesson that we've learned from both SMA and Duchenne is that labels might be broader than the clinical trials. Again, because we're trying to capture endpoint in a select group of patients, clinical trials often have narrow inclusion criteria, meaning you have to be a certain age, you have to be a certain functional status. But then when the drug is hopefully approved, it often includes a broader group of patients. And so we've seen this in recent years. Idvisma, which was the intrathecal therapy for SMA that was just approved, is an example of this. And so the clinical trials were in patients ages 2 to 18, all of whom could sit, none of whom required permanent ventilation. And then the label that just came out has no age restrictions, no functional status restrictions. And so we don't yet have data in adult patients or patients who might have, more severe respiratory disease. And so we're left to kind of figure that out together. Similarly, Elevidys for Duchenne was granted an accelerated approval for non-ambulatory patients in June of 2024. And there's been an ongoing randomized control trial in this patient group. So when it was approved, there wasn't yet data on effectiveness in this particular group of patients. Subsequently, there were 2 deaths from liver failure in this group of patients, which led to a clinical hold in June of 2025. And so I think these examples raise the question of how do we assess acceptable risk benefit in rare and progressive diseases? And where is that bar? Patients understandably want access to therapies. And how do we, decide what's appropriate with shared decision making for therapies that might be irreversible or have the potential for severe side effects, like gene therapies. And so when you're talking to your doctors or your care teams about therapeutic decisions, these are some of the questions that you might want to ask yourself or talk about as a family. And so, again, is there specific data in patients like you or patients like your child? What specific benefits do you think that the therapy might offer you or your child at your current disease state? And then what are the risks? And do you have any medical conditions that might increase your particular risk of this therapy? I think the coin flip to that question is, what are the risks of not starting? Like, what's going to happen if you don't try it? And also, what are the expectations? Has this therapy been studied in combination with other medications that you might be on? Is this a one-time therapy and irreversible, or can you get additional doses in the future? And one question that comes up not infrequently in the neuromuscular space is, could getting this therapy now potentially exclude you or your child from a future clinical trial or a future treatment? And a lot of this comes down to, how do you as a family or you as a patient weigh the potential for risk versus benefit? And so kind of moving into that risk versus benefit conversation, I think one of the big lessons that we've learned from our current gene therapy programs is related to toxicities. And so we've learned that giving these therapies requires very close follow-up. As neurologists, we are not experts in the immune system, but we've had to learn a lot about the immune system and partner with our colleagues in other areas of medicine and try to understand, how does the immune system relate to AAV? And so that knowledge is evolving, and that knowledge is complex. And we are still learning, exactly how these therapies interact with the immune system. We've also learned that because these trials are small, new side effects might emerge after a therapy is approved. And so vigilance is required anytime a new drug is approved, to sort of look for new safety signals or recognize things that we need to watch for. And I think, again, as more therapies have been approved, we started to recognize that certain toxicities are class effects of AAV, whereas others may be disease specific. And I think when we give these high dose therapies, we can unmask underlying patient vulnerabilities. And so again, I think, I always think of gene therapy as a partnership, and that my role is to do everything possible to keep my patients safe during this process, but that a family or a patient's role is to really understand what is expected of me and make sure that that's something that they're able to commit to. And so really that comes down to informed consent. That comes down to adequate education, making sure that patients and caregivers have had, full opportunity to ask all their questions, to get all the information that they need to make the best decision. And that means ensuring adequate time for these types of visits. And, again, every protocol is a little bit different. Every drug label is a little bit different, but typically labs are required at minimum weekly for 8 to 12 weeks after dosing. And there's often a low threshold for an additional subspecialist evaluation prior to treatment, or a low threshold for additional labs or evaluations if any clinical concerns arise. And so again, I'm not an immunologist, so I will try not to bungle this topic. But I think, when you give AAV, it can stimulate the immune system in a number of different ways. And so anytime we give a large viral load, even though this virus doesn't cause disease in humans, our body can kind of recognize contents as foreign. Our innate immune response can release a group of proteins called cytokines. It can activate what's called the complement system, and AAV is thought to bind to the complement system. And then it can, some of these early changes can then trigger immune tolerance or the sort of initiation of our adaptive immune system. And so all protocols require some level of immune suppression to try to dampen down this immune response. And so, when you have this innate immune response, the AAV can bind to something called toll-like receptors. It can recognize different components of the AAV capsid itself, or the vector, or the protein, and that can really lead to complement activation and other sort of cascading downstream effects. And so there are ongoing efforts to try to understand how do we best prevent toxicities, and also to understand which patients might be at increased risk of toxicities. And so again, this is a complicated slide, but just, I think, emphasizes all of the different ways that AAV might potentially trigger your immune system. And then that's also led to targeting of kind of different parts of those immune system, both for prevention of toxicities and treatment of toxicities. And again, depending on factors related to the manufacturing process, like vector purity, how high the dose is, what tissues you're targeting, we can see different toxicities. And so I think one of the lessons that's come out of approved therapies is an understanding of something called thrombotic microangiopathy. And so when Zolgensma was approved for spinal muscular atrophy, there were no reported cases in clinical trials, although there were some reports of low platelet count or thrombocytopenia. And so TMA is thrombosis in the microvasculature due to endothelial injury. It typically occurs 5 to 14 days post-vector administration. Symptoms include irritability, vomiting, decreased urine output, kidney injury, and hypertension. And you can see drops in hemoglobin, increases in creatinine, which can be complicated in muscle disorder, and then abnormalities in complement labs. And so, learning about this through SMA has been really important, as it's now been seen in other programs. And so it's something that came out post-label, but now something that if you're starting, or participating in an AAV clinical trial or giving a commercial AAV product, that we now all know to look out for. And then there are a couple examples of this that I'll go into slightly more detail of, but I think anytime you're giving this large dose of virus that stimulates the immune system, we've learned that can kind of unmask perhaps unique patient vulnerabilities. And so we've seen this in the clinical trial program for a disease called X-linked myotubular myopathy, and we've also seen this a little bit in Duchenne muscular dystrophy. And so I think one other lesson we've learned is that it's important to try to maximize patient health across organ systems prior to administering gene therapies. And so X-linked MTM is a rare X-linked severe congenital myopathy. It occurs in 1 in 50,000 male live births. It manifests as severe weakness and ophthalmoplegia. Without treatment, 25% of patients die in the first year of life, and 85% are ventilator dependent on a ventilator to breathe and a G-tube to eat. And so myotubular protein is ubiquitously expressed, but its function outside of skeletal muscle is unclear. And there's an incompletely characterized natural history because of the high mortality early in life. And there had been some recognition of liver pathology, but not related to the bile transport system. And so this was a trial using AAV8. It had really impressive preliminary efficacy, improvements in respiratory and motor function, ventilator independence in 16 of 20 surviving subjects. And preclinical studies in mouse and dog models, as well as non-human primates, didn't demonstrate any, significant liver toxicity. And anyone who had, significant pre-existing liver toxicity was excluded from the trial. However, unfortunately, there were 4 subjects that died of liver failure after receiving this treatment. They developed abnormal liver function and progressive cholestatic hepatitis. Multiple interventions were tried, but unfortunately were not successful. And so this was thought that, the AAV triggered hepatotoxicity, which has been seen across multiple programs, exacerbated an underlying liver vulnerability in these patients and led to a more severe presentation. Similarly, in Duchenne muscular dystrophy, there have been a handful of cases of sort of severe hyperinflammation and cardiac toxicity. This was seen in the Pfizer clinical trial, and there was 1 death in a non-ambulatory patient that happened, in the week after giving vector. The patient developed an increased marker of cardiac inflammation and then cardiogenic shock. And this was also seen in a patient who received an CRISPR gene editing product given via an AAV9 vector and had sort of a large inflammatory response to that vector. Additionally, in Duchenne muscular dystrophy, immune-mediated myositis was seen with 5 cases across 3 different DMD clinical programs. Patients developed weakness, respiratory difficulties, and feeding difficulties, had significantly increased muscle enzymes. This occurred 3 to 6 weeks after treatment. And this led to multiple companies and academics kind of coming together to say, hey, what is it about these patients that seems to trigger this? Because this has not been seen in many other patients. And so it was mapped that sort of all of these patients had an overlapping deletion in exons 8 to 9. And it was thought that potentially triggered sort of an attack on the gene therapy product itself, leading to this myositis that subsequently led to a exclusion of patients with these types of genetic changes from clinical trials and from the commercial label, and then future cases haven't been seen. So the other toxicity question is, since these are new therapies, it's possible that side effects might emerge later. And so long-term monitoring is necessary for effectiveness and for toxicity. But it's complicated, right? These therapies are super labor intensive. Patients, years out, they move or, have different things going on. And so it can be hard to maintain consistent follow-up. And so how do we build systems that allow us to follow patients who've received gene therapy over many years and across healthcare systems so we can better understand the long-term effects of these therapies? And so there are lots of very smart basic scientists. I'm not a basic scientist. I will not pretend to be, who are trying to come up with solutions to many of these various problems. So things like lowering the vector doses by engineering capsids to have higher potency for target tissues, improving the immunosuppressive regimens to prevent some of these toxicities for developing, to modulate the immune system and get rid of antibodies so that either patients who are antibody positive or who have received doses of gene therapy before can be redosed, and then really looking at non-viral, so non-AAV delivery systems that might have fewer side effects and might be more effective. And so in the DMD space, there are multiple companies who have ongoing trials. So REGENXBIO has a more intense immunosuppressive regimen, including sirolimus and eculizumab. And their construct includes something called the C-terminus domain. Solid Bio took some of the side effects they experienced in an early clinical program and engineered a second-generation capsid designed to increase targeting of the muscle and to detarget the liver. And they also improved their manufacturing process to try to reduce toxicities. And include something called the nNOS binding domain. And then a company called Insmed is looking at administering the gene therapy via lumbar puncture into the intrathecal space. And this is not meant to be an exhaustive list. There's other stuff happening as well. And then preclinically, there are a couple of different approaches. So one is using engineered capsids, again, trying to target trying to target the muscle in the heart at better levels. And then similarly trying to detarget the liver, which is the cause of toxicity in some patients. And so these engineered capsids, you can modify the virus shell, you can improve the target cell entry, you can work to help evade the immune system, to name a few different approaches. Another approach that's being worked on by their Chamberlain lab at University of Washington, as well as others, is something called split intines. And so that's where you're delivering 2 separate protein pieces that then find each other, bind, and sort of are able to then produce a single mature protein, acting as like a molecular Velcro to then produce a longer version of dystrophin. And then looking at non-viral delivery approaches, which can be utilizing gene editing, as well as gene editing using CRISPR that's delivered via AAV itself. And so I think it can be overwhelming to try to like follow all the science, to try to know where do you look for these things. How do you search if there's something that you might be eligible for or something that your child might be eligible for. And so I've put a QR code here. This links to the MDA clinical trial website. And there's a great interactive search tool. So you can type in your age, how far you're willing to travel, might ask you some additional questions about yourself. And then it'll sort of pop up if there are any trials that you might be eligible for. Similarly, clinicaltrials.gov is a great resource and lists sort of all kind of upcoming and actively enrolling trials. And it's a good thing. I often recommend my patients check it out at least every 6 to 12 months. We obviously do our best as physicians to keep up with everything, but there's so much happening that it can feel like drinking from a fire hose. And so it's always good to sort of know where to look. And so again, this is not meant to be an exhaustive list, but these are some of the diseases that have clinical trial programs in development. Some of these programs are already enrolling. And so, you can see there's Friedreich's ataxia, some types of limb girdles, Duchenne muscular dystrophies, Duchenne, some types of Charcot-Marie tooth, OPMD, congenital myopathies, congenital myasthenic syndrome. Again, different programs are in varying phases of development. I wish that I had time today to kind of talk more about some of these individual diseases and where things are. But unfortunately, an hour goes by quite quickly. So suffice to say that there's a lot happening that is exciting for many different diseases. And then there are many RNA trials. So myotonic dystrophy and FSHD are two diseases really looking at gene silencing. And a lot of these approaches are using RNA approaches. And then in Duchenne muscular dystrophy, there's a lot happening in the exon skipping space. And so just to touch briefly on non-viral delivery options, this is a little bit further away. But I think many patients excitedly saw the headlines this year about baby KJ, who was a metabolic patient with a severe disorder called CPS1, who received a custom gene editing treatment using CRISPR base editing delivered via something called lipid nanoparticles. And this treatment ameliorated his severe disease phenotype, which was incredibly exciting. It was to have a patient receive a custom gene editing treatment. And so this has obviously generated a lot of excitement in this scientific community. I know I got many questions from my own patients saying, is this something that would be an option for me with my muscle disease? And so I am not an expert in lipid nanoparticle biology, but suffice to say that lipid nanoparticles are great at getting into the liver, but getting them to tissues like muscles isn't so easy. The liver kind of acts like a super absorber and takes up the LNP before it can get to the other body tissues. And so right now, LNPs are super promising for disorders that sort of occur in the liver. And I think there's hope that this might be a delivery mechanism for the future that has fewer toxicities, that could allow redosing. But there's still a lot of work to be had in terms of how do we effectively get them into tissues like muscles and nerves. So just wanted to briefly mention it because I know some headlines that many people have come across in the last year. And certainly quite exciting for the field of precision genetic medicine. So in summary, genetic therapies in neuromuscular diseases are rapidly expanding. Gene therapy is a broad umbrella term that encompasses many different types of therapies. And early approvals of AAV therapies in DMD and SMA have led to important understandings of toxicity, and these clinical experiences have helped shape the next steps in clinical development. I think we've learned that the delivery of precision genetic therapies is a complex process. It requires thorough counseling of risks and benefits and close partnerships between patients and community advocacy organizations and treating teams. And that there are multiple different approaches in the gene therapy space that are being studied. And so there's significant optimism for precision therapies moving forward. So with that, I will stop sharing and turn it back over to Tess.
Thank you so much. That was such an informative presentation, and we have lots of praises for you in the chat right now. Let me get my screen shared, and then we will start a quick Q&A. Now, typically we have like a lot of different styles of questions, which we do here as well, but we also had a lot of questions about specific diseases and their chances of receiving gene therapy or the potential of something being developed in the future. So I was hoping we could start our Q&A quickly with a lightning round, so to speak, of some different rare diseases. And if you know if there's anything in development right now, I know you touched on this a little bit, but these are the ones specifically in the chat we had. Would that be all right?
Sure.
Okay, great. So the first one was myotubular myopathy.
So are you talking about X-linked MTM or?
They did not specify in the chat.
Okay.
Just said they were an adult, an adult living with a rare neuromuscular disease, myotubular myopathy.
Got it. So probably not X-linked myotubular, like X-linked MTM then. I'm not sure about that one offhand. I apologize, but I would encourage you to go to the clinical trials website and check it out. I'm a pediatric doc, so I'm not quite as versed in what's going on in the adult world.
Yeah, absolutely. And for everybody, if we're not able to answer your question today, or if you think of one later on, we do have our resource center that's available 24/7, and you can reach out to MDA and get one-on-one support. So if you do have those questions, need help with the clinical trial database, any of that good stuff beyond today, please reach out to our resource center, and we'll have that information in the chat and at the end of the slides. Okay, anyway, so what about Bethlem myopathy?
Yeah, so Bethlem myopathy, there's a lot of animal research going on in that one. Again, some of the ones I see in the chat are complicated genetically because Bethlem myopathy can be caused by both autosomal dominant genetic changes and autosomal recessive genetic changes, meaning they're kind of different types. And so I also saw comments on RYR1 and ACTA1, and both of those sort of the same applies. And so there are also nuances in terms of even if we do develop gene therapies, whether or not, your specific type of myopathy is amenable are complex discussions. But I think a lot of the disorders that I see in the comment do have mouse models, which is often the first step in terms of developing therapies. So kind of the pipeline for clinical development tends to be we study things in animals first, see if it's effective, and then ultimately move to dogs or primates to see, and then if there's positive data, move on to humans.
Great. Well, a first step is always the first step. So it's nice to have something moving in that direction. Another rare disease we had asked about was ocular pharyngeal muscular dystrophy.
Yeah, so that one there was again, I'm not an adult neurologist, but there's been some preliminary data, I believe, at MDA last year. This was presented. I think a handful of patients have already been treated through that program.
Great. And then we had a couple people ask about Selenon-related myopathy.
Yeah, so I don't think there's a specific active gene therapy trial for Selenon right now, but this is another one that has a mouse model. I think people have tried some, non-gene therapy things like supplements and things like that in Selenon.
Great. What about RYR1?
Yeah, RYR1 is another one similar to Bethlem, where there are a bunch of different genetic types. So also lots of work happening in RYR1. But again, depends on sort of the specific types. I don't think there are any actively enrolling trials in that disease right now.
Okay, great. Yes, everybody, please make sure you can always reach out to our resource center again if you want updates or support with this. The last one of the, and I know this is OPMD, which is adult, but OPMD with leg weakness was another one that had been mentioned.
Got it. So OPMD, I think we just talked about that. There was some data presented at MDA last year. I don't know the specific trial inclusion criteria, that one, but there has been a program. I also see a couple of comments about FSHD and myotonic, and those are two areas where there's a lot of therapeutic development happening. So there are ongoing clinical trials for both myotonic dystrophy and FSHD. Most of those are RNA therapy based right now, but definitely look up those programs.
Great. All right. And just a few general questions as well. Are there tests that can be done to try to predict how your body will accept the gene therapy? This person specifically asking for Advisma.
Yeah, so I think in terms of like how your body responds to the therapy, meaning like how well you react, I don't think we have great tests for that. We are obviously able to test the antibodies to see if there's a contraindication. I think sometimes for Ibisma specifically, we might do some of the functional scales to sort of understand where in the disease process you might be and think about then how it might what types of benefits you might expect to see.
Great, thanks. So do problems with graft versus host diseases occur?
So graft versus host disease is typically something that's seen in ex vivo therapies. So those are therapies that are given via bone marrow transplant. And so most of our neuromuscular therapies are not typically given via bone marrow transplant. And so for in vivo therapies, we don't typically deal with graft versus host, but that's definitely a concern in ex vivo therapies.
Got it. So someone said this is very informative and great information. Thank you. Do you see more gene therapy and editing options coming soon for LGMD patients?
Yeah, I think that is definitely an area of active interest. I think I just saw a LinkedIn post from Cure Rare Disease that they just received funding for an LGMD trial, I think for R9. So it's definitely one that's being studied a great deal.
Okay, great. Well, this is the last question that I have in the chat from my end. And this person said, thank you for a great discussion. You are my son's neuromuscular doctor at CHOP, and we love you and your team. That's always nice to hear. Are there any plans to explore gene therapy for ACTA1 congenital myopathy?
For ACTA1, yeah, so that's another one where there's a lot of research happening. Again, ACTA1 can be both autosomal dominant or autosomal recessive. And so the approaches can be a little bit different, whether you're turning off a protein or giving or silencing a protein versus giving back a protein. But these are definitely ones that are in the scientific pipeline, not yet quite ready for prime time.
Great. Someone asked, are non-viral gene therapies less expensive?
That's a great question. I don't know about the manufacturing costs for non-viral gene therapies, so I can't comment on that.
Yeah.
But that's an excellent question.
Is there a chance Advisma increases strength, or is it only to halt progression?
So I think, again, the sort of typical, understanding is that gene therapy can't reverse the damage that's already occurred. So in SMA specifically, I tell my patients that any of our treatments can rescue vulnerable motor neurons, but that they can't necessarily give back motor neurons. And so, some patients might receive a little bit of a boost, but I think the general expectation is that it's sort of halting progression. And any type of boost or gain is an amazing bonus, but that's not necessarily the expectation.
Okay, thank you. And then I think our last question for now, we're going to finish right on time. Wow, that never happens. What about MELAS, MELAS?
MELAS, that's a mitochondrial disorder. At CHOP, we have an amazing mitochondrial team that sees a lot of the mitochondrial patients. So I'm not super well versed in that world. So I can't comment on that. I apologize.
Yeah, no, of course. So everybody, again, please reach out to our resource center if you need support. Marissa has been in our chat adding all of MDA's wonderful gene therapy resources as well. So please look through that chat and take advantage of that. We have a lot of resources to help you. And this, like Dr. Matesanz said, it's an exciting time in this space, and so much progress is happening. So thank you so much, Dr. Matesanz, for joining us today and for your care and support of the MDA community. Thank you.
Thank you guys for having me. This was wonderful. And thanks to the MDA for organizing this event.
Thank you.
Take care.
Let me get situated here. Just one moment. So with new gene therapy drug approvals in the pipeline, MDA is here to facilitate access and provide support and education. We offer both one-on-one support as well as group support, print-ready educational materials, self-guided learning modules, and webinars like the one today. If you have questions or are looking for support, please contact the gene therapy support specialists at MDA. MDA would again like to thank our program sponsors, Regeneron Pharmaceuticals, Regenx Bio, and Sanofi for sponsoring our program today. We thank you so much. This year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with rare neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum towards transformative progress for people living with neuromuscular disorders. To learn more, please visit mda75.org. Last but not least, we again invite you to join the MDA community, as you probably already are. Joining is free and will help you stay up to date on our programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. We would again like to thank Dr. Matesanz for sharing her time and expertise with us today. And thank you for attending. We really appreciate it. And we'd like to hear from you. What did you like about our program today? What can we do differently or better in the future? Please fill out the brief survey that will pop up right after the webinar. Your feedback is important to us. And again, if you have any questions or are looking for support or resources beyond this webinar, please contact our resource center. That number is 1-833-275-6321, 1-833-ASK-MDA1, or via email at resourcecenter@mdausa.org. So thank you so much for joining us today. We hope this was informative, and we will see you again on the next one. Bye.